All right, we're now live. Hi, this is Elliot Fishman. Welcome to Facebook Live. Today is July 3rd. Happy July 4th to everybody. Happy to all the new residents, all the new fellows, all the new faculty. I'm in my other office, by the way. Yes, you see behind me some Next computers, teaching files, and all sorts of good stuff. We're having a little bit of issue with some of my one of my workstations, so my other office, the guys are trying to fix things. Anyway, it's a new year. Hope everyone is making the transition well. Hope everybody is keeping cool. The weather out here is in the high 80s. Hey, it's the summer. You can't complain. And surely we're not in the Atlantic where they're having all those terrible hurricanes. We wish everyone down there in Jamaica, especially today, only the best. We have a lot of fans and friends in Jamaica. I don't think I've ever been to Jamaica, to be honest. But anyway, today's topic I have down is mediastinal masses. I am doing some work on new lectures. I think we have a lecture from a few years back on mediastinal masses. I'm working on some new lectures. I think the important thing about mediastinal masses is really how we approach them. I think that's the critical thing. You know, it's one of the things you're taught as a first-year resident, right? Where is the mass? Is it anteriorly, middle mediastinum, posteriorly? We know that based on location, without even looking at the scans, you can predict what you're dealing with. Anterior mediastinum, we talk about, the thymoma, teratoma, thyroid, lymphoma, 3 T's and an L. Posterior mediastinum, we're more likely to talk about neurogenic tumors. Middle mediastinum, we think about bronchogenic cysts, duplication cysts, things like that. So those are all things we potentially will consider. Of course, when we do the actual case, we're going to look. How does the mass look? Is it vascular? You can think about particularly middle mediastinum, Castleman's disease when it's very vascular, or a neuroendocrine tumor. Lymphoma typically is relatively hypovascular. Infiltrative, typically anterior mediastinum, but can involve every department or compartment. We talk about neurogenic tumors. Often there's changes in bone that can be present. You can think about neurogenic tumors as being low CT attenuation. We can think about anterior mediastinal masses that really aren't the 3 T's and an L. Like I saw a case the other day of a big myeloma mass that presented as an anterior mediastinal mass, but was really a sternal mass. We could talk about pleural-based masses like that. We could talk about lung cancer. So you want to really get a feel of what could be where, but then you need to see a lot of cases. And that's one of the things we try to do on CTisus. You go to the teaching file, you're going to see a lot of chest cases, a lot of mediastinal masses. And the lecture is going to try to show you mediastinal masses and how we distinguish them. Again, you can have small masses sometimes. And a small mass in a patient who's hypoparathyroid could be an ectopic parathyroid adenoma. That's uncommon. If you have a teratoma, usually it has calcification, maybe some fat, could have a fat fluid level. Mediastinal masses will also at times vary on patients' ages. Though it's not perfect, but thymomas are more likely in a 50-year-old, not a 15-year-old. If you have a thymic mass in a 15 or a 10-year-old, it's likely a thymolipoma or a thymic cyst. Lymphoma crosses the age spectrum. Metastasis can go to the mediastinum. Renal cell cancer, melanoma are 2 good examples of that, and we see lots of cases there. So I look at size, distribution. I look also obviously outside the mediastinum. If you have a mass in the mediastinum anteriorly and you have splenic and liver lesions, there's likely going to be lymphoma, could be melanoma, could be metastatic something else. So the extramediastinal findings become very important. If you have lung nodules, it's a good chance it's metastatic disease, but not necessarily. So how we look at things and how we think of things becomes very, very important. We then also need to then look at, as I mentioned, you look for calcification, you look for fat, you look at an enhancement pattern. You want to make sure you're not being confused by a vascular lesion. Aneurysms or pseudoaneurysms, particularly in a non-contrast scan, can fool you. One thing I recommend, and yes, I don't need contrast to see a mass, But for me to really understand mass involvement, including vessels, including its enhancement pattern, including a number of things, I need IV contrast. So we like to use IV contrast routinely. I like to do multiplanar reconstruction, even 3D imaging can all be very helpful in that regard. One of the other things, again, routinely, at a minimum, you need to look at multiplanar reconstruction. There's no doubt about it. As I mentioned a few moments ago, mediastinal mass, you're going to scan the entire abdomen eventually, because I saw a case recently of a mass that looked like lymphoma. It was seminoma. Things like PET-CT can be helpful, but again, PET's is positive on almost everything in the mediastinum, so it's not really going to give you a great differential diagnosis. Again, also history becomes important. Has the patient had a diagnosis of something before, and what we're dealing with is a recurrence? So, you know, we can't get around the basics of imaging, which is, you know, we're July 3rd. So let's go back to basics. So what I'll do is I'll be showing you a bunch of cases. Hopefully I'll get it done this weekend, which means when you speak with Sarah, it'll be sometime the end of August. You'll be able to see the lectures. But we're also posting stuff on Facebook daily. There was some mediastinal masses this week and some very interesting cases. So I know everybody's busy today, so I'll make this a little bit shorter. I wish everybody a great July 4th, and especially those people who are working, and we have a quick Friday work, and then we have a weekend. So hopefully everybody's doing okay. I see Lydiana in New York. Hey, Lydiana. Lydiana's the only person who made it. It's interesting now, we have a large number of people who see these Facebook Live, but because it's 12 o'clock, people often watch it remotely, and that's one of the things, of course, that's great about the web. 24/7, 365, you can see everything. So with that, I thank everybody for their attention. Hope everybody has a great day, and see you soon.